appreciate those of you who take the trouble to join us quite regularly for these events. As I've said before, but I want to stress it now, we are a community, and the fact that we come together in this way as a community, I personally really appreciate. You're giving your time, I'm putting in my time, and we're working together. And also it makes a huge difference if people are returning regularly to the same issue. It means that we can advance together through exchange and dialogue, and now is more important than ever. Catherine Deland, who's on now, great, and I are fresh from quite an important gathering of the 6 WHO special envoys with Tedros, the Director General of WHO, and working with Tedros over a period of an hour and a half, and informed by WHO specialists from all over the world, we were able to review the current state of the COVID pandemic, and we were also able to explore some of the really difficult issues that are being faced. You are joining from all over the world. I am going to be quite rigid in my timing today, because I very much want those of you who have joined from Africa, from Latin America, from Asia, if it's not too late for you, as well as from different parts of Europe. And I want people in North America as well. I want all of you to feel encouraged by me to be ready to come in with comments and reactions, because today I will give you an update on our view of the state of the pandemic and of responses. But I think that, as is often the case, today will be better as an exchange of thoughts and ideas. And particularly if you've been on before and you brought up a specific issue, for example, long COVID or schools or vaccines, don't hesitate to come back to it. And I'll tell you why. I mean, the pandemic epidemiologically is as fierce as I've known it right now. It's really very serious indeed. And I mean, it's difficult because there are a few countries where there's a lot of vaccination being done, and there's a bit of a feeling in those countries that the whole thing is somehow becoming history, but it's not. I think this pandemic is set to go on for really quite a long time to come. I think the virus is almost certainly going to become endemic in human society, and I think it's going to go on troubling humanity quite a lot. And I personally suspect for quite a lot of years. So a lot of trouble and a lot of years for this pandemic. And I'm not going to show you the epidemic curve, but I'm going to describe to you what I'm hearing happening around the world from my various sources. Okay, to Rebecca Cantor, let's start by going to where you are in Chile. Why not? Good point. Very high coverage with vaccination, and yet at the same time, a really serious situation with the virus. Heavy burden on the health system, extremely serious lockdown. Several of my friends working in Chile have got COVID right now. The virus is surging much more seriously than it was last year. Same in Argentina. Brazil, extremely serious. And then we go to other countries in Latin America. The story is coming back again and again that there are areas where you've got high levels of illness, high levels of hospital attendance, overloaded hospitals, overwhelmed personnel, shortage of care, facilities like oxygen, and a general despair in the population, just that it doesn't seem to be going away. Caribbean, islands are starting to get a lot of COVID now. And when you get COVID on a Caribbean island, you have to be very diligent to stop it spreading. United States, hugely variable. Overall, the numbers are reasonably static. But as with everywhere else, just because the numbers are not shifting overall, it doesn't mean that the virus isn't swirling around and is perhaps building up and spiking away in certain parts of the country. Canada, particularly serious. Those of you on from Canada will be able to describe some of the situations, particularly in the west and center of the country. Europe, France, in considerable difficulty with health services in particular, full, and variants moving more widely. Other parts of Europe, the further east you go, the tougher the situation is. Greece in difficulty, Ukraine in difficulty, and then Poland, Hungary have also got a lot of COVID. India, perhaps the most disturbing of all the countries. I talked about it last time we met, but the situation in Maharashtra is disturbing. And there are a few indicators in India that are causing concern to the government. One is the high percentage of COVID tests that are coming back positive in India, despite the fact that there's been a huge ramping up of test capacity. So it can't be attributed to limited numbers of tests. No, the high positivity rate, particularly in Maharashtra, is telling us there's a lot of disease. Last week, I mentioned Bangladesh was in lockdown. It's been, I believe the lockdown continues for another week. Indonesia, very heavy COVID situation there. Nepal, serious problems. And then in the Middle East, Iran, lots. North Africa, a lot. And in the Gulf region, quite variable. Taken all together, this is surging away, this virus, and it's not as though death rates are dropping either. They are high, and this is showing us that there is still mortality associated with the virus. Disturbing reports from Brazil are that the average age of people in intensive care has started to drop, and we now have the predominance of people in intensive care in some parts of Brazil less than 50 years of age. What's going on? Well, I suppose most important to say is that, as we've always maintained in these briefings, the virus is mutating constantly, and some of the variants that emerge as a result of mutation are particularly disturbing because they are more easily transmitted. In some cases, they seem to cause more severe disease. And because of situations like what we're seeing in Chile, there are worries that some of these new variants are capable of evading the protection provided by the vaccines currently available. As just repeating myself, but I want to be consistent. It is inevitable that variants will emerge that are capable of evading the currently available vaccines. It's just a case of when will it happen, where will it happen, how serious will it be? And so to countries that are proud of high levels of vaccination right now, I say great, well done. But I'm also saying this doesn't mean you can suddenly stop everything and behave as though the pandemic has ended, because the variants will come. And in order to protect ourselves against the variants, we will rely on the non-pharmaceutical interventions of physical distancing, mask wearing, really good personal hygiene, highly enforced self-isolation when we are sick, and shielding those who are most at risk. And the best forms of shield available now are these vaccines, because they provide a biological shield that for the time being protects older people, But of course, we will also need to be ready to go back to physical shielding, given that as soon as we get a variant emerging in the community, we have to be double careful, treble careful that that's not going to turn into a surge. Okay, so I start with this super depressing news. The pandemic is bad and it's getting worse. And talking with WHO friends, I think for the first time, I had a sort of sense of just really major concern about the inappropriate narrative that is present in some national capitals, particularly in countries that have got high levels of vaccine rollout, about what's really happening. This pandemic is still a major problem for most countries in the world. This pandemic is still causing huge numbers of cases. Do you know, on the 14th of April, how many people with COVID were reported to WHO just 2 days ago? It was 800,000 in 24 hours. Last year at the beginning of the outbreak, obviously there wasn't so much testing being done. It took many weeks to reach a reported number of 1 million cases. About 3 months. It's now nearly 1 million in a day. This is just huge numbers. 13,000 people died yesterday, reported to be having COVID. When I hear the figures of daily deaths from Brazil and from other countries like India, I just find myself really having to stop and remember how much more serious this situation is now than it was at the end of January. Seemed to be just about double the number of cases being reported every day compared with the end of January, and how much more serious this situation is now than it was in April, May last year. In my discussions with Tedros, we were saying it's almost as though world leaders need to have a total reset and to just say, well, supposing we were just coming into this situation now from scratch with 800,000 cases a day, with multiple new variants emerging all the time, and with 13,000 reported deaths, but probably many more. Would we not be much, much more alarmed than we actually are? Because we've been dealing with this pandemic as an evolving situation. And when things shift from one day to the next or 1 week to the next, it's terribly difficult to remember what the intensity was, say, 3 months or 6 months ago. Well, in summary, the intensity is about the same as it was at the end of December, beginning of January. But the distribution is what's changed. It's a huge upsurge in the amount of COVID in South Asia. There's a growing increment in Latin America that really has taken off, particularly in South Asia, but also in parts of Latin America. What does this mean? Well, it means that it will come back with a vengeance in the UK. There's just not enough immunization done to create nationwide population immunity. It's not quite clear how big the resurgence will be in the UK or when it will come. It will depend presumably on which variants are at the front end of that resurgence, but it will come back in the UK, just as it's come back in India. And the message that I will try to communicate in my media work, I'm doing very little now, but I've got one later today for the UK, will just be, look at what's happening in the rest of the world and don't imagine that somehow the UK is different from other places. It might as well just prepare for it. And that means that as all the excitement and joy and jumping up and down, going to the pub and so on, people experience, which is absolutely right and desirable, and nobody would want that to happen more than me. There's got to be a really large amount of careful advanced planning for what happens the next time there's a massive surge. can we really put in place the steps that are necessary to contain it? Well, I personally think that that can be done. So I now come to my basic prescription of the things that must be in place to deal with the pandemic. It might help you that I work with 5 P's in my head. The first P is pandemic. Remember what's happening with the pandemic. Remember what the outbreak curves look like. Remember the spiking and the surging, and just keep that in mind. Number 2 is people. I never tire of saying the virus is the problem, people are the solution, because it's true. And the reason why I say it is that we will not move to a point where people become the solution globally until a way can be found for governments to engage with their people in a way that recognizes and rewards the incredible amount of effort that everybody everywhere is putting in to keep themselves safe and to keep their societies safe. People are not the problem. And I'm trying to stop making any remarks about groups of people congregating and therefore spreading the virus. It's too easy to blame it on the behavior of individuals. And the reality is that when people mingle together, the virus is more likely to spread, and we know that. So of course, as restrictions in the UK are released, as restrictions in Italy are released, restrictions in Germany are released, because governments feel that the populations are not prepared to cope with the restrictions anymore, there will be surges, and the necessary challenge for all governments everywhere is to level with their people and say, yeah, okay, you're fed up, we're all fed up, but the reality is the virus is not fed up, and this is just going to go on. And to use the examples of India, or the examples of Brazil, or the examples of Argentina and Chile, the examples of Iran, examples of other East Asian countries, particularly countries that have done really well in getting on top of this thing, to use the examples to point out that the virus doesn't suddenly disappear. In brackets, I remain hopeful that there will be a miracle and the virus will suddenly disappear from personal reasons, close brackets. And I repeat, the virus doesn't suddenly disappear. So people are the solution. And I will say it so often that I get almost tired of saying it myself, but I don't hear enough other people saying it. So that's why I want to keep saying it. Number 3, public health, community-based, well-organized and integrated, linking together health professionals and local authorities. Public health at the local level is absolutely critical to keeping the spikes from turning into surges. If you're operating at incident levels of 50 to 100 per 100,000, the public health people, at least in the UK, can manage it mostly. If it gets up to 150 to 200 per 100,000, then it starts to evade the control of the public health services, and it starts to become a major problem with surging and then a potential of an explosive outbreak. So I'm saying to everybody, don't neglect the public health. Without the public health and the focus on interrupting transmission, we're not going to be able to deal with it. Henk Bekkerdam, who often joins these calls, is perhaps the most ardent advocate for promoting community-based public health. If you're here, Henk, I'm singing your song. We have to explain what public health is. At Chatham House earlier this week, I found myself suggesting that we sometimes need to stress that public health is not hospitals. It's a part of the health service that's designed to keep us all healthy. But in Western European countries, the budgets for public health have systematically been raided over the last 20 years in order to put more money into curative care and hospital services, which under normal circumstances, you can just about get away with. Of course, inspections of restaurants perhaps are not done so regularly and all that stuff. But now we've been caught napping, and by not investing satisfactorily in public health, by not creating the proper career opportunities for people in public health, by not making it an attractive professional discipline, by not ensuring that the budgets are kept constant rather than being cut almost in half over a small number of years, we have, as nations, and it is Western Europe and the US, we have seen investment in public health in real terms drop markedly. So I am campaigning for greater investment in public health everywhere. The next thing that we need, beginning with P, is a program. We need a global COVID program, like we had a global AIDS program in the period, the late 1980s, like we've had a global polio program to deal with the effort to try to protect against polio, like we have measles programs. We need a COVID program because this virus is becoming endemic, and it's just crazy to try to deal with an ever-changing and rapidly advancing virus using multiple vaccines, some of whom have not been through their phase 3 testing, but they're still being used. To deal with this with nations operating independently is just total nonsense. And every global expert is just crying and burying their heads in their hands and just completely unable to understand this steadfast wish by national leaders to behave as though somehow it's okay to be sovereign on this thing. Just look at where the sovereignty is leading to us. A whole series of different protocols for deciding what to do with society and the economy in the face of COVID. A whole series of different protocols in deciding how to stop the virus from spreading. A whole series of different protocols for deciding whether or not to suspend the use of different vaccines like AstraZeneca or Johnson & Johnson. It's almost as though national governments have decided that there's really no point in trying to establish any global conventions on what to do, but instead it's better, safer, and somehow, even in the long term, economically superior to just try to deal with it yourself and to navigate through your own public health advisors and do it that way. Well, it's not going to work. And I mean, we've dealt with complex issues that go across borders before. We've managed to have global programs and global operations before. We will sooner or later work it out on COVID, but I hope that we don't have hundreds of thousands and more people dying before there is some degree of global coherence about what a program might involve. Today, discussing with Tedros, it's quite clear that he is trying to get something ready and he's waiting for the right political moment to unveil it. You see, global program would include the epidemiology, it would include the work on therapies, it would include the work on diagnostics, and it would include the work on vaccines. It would be very much at its center having a tracking service for looking at the emergence of variants of concern, and it would keep an eagle eye on what vaccines are being used where, with what possible side effects, in order to try to standardize the way in which these issues are being dealt with. It would not try to stop unlicensed vaccines from being used, but it would keep a weather eye on what was happening as a result of unlicensed vaccine use. It would be the place from which the discussions about international travel could be undertaken, and the vexed issue of vaccine passports, which, unless they're introduced with great care, will cause lots of schisms in society, could be discussed through the global program. And the global program would also be the place from which new science could be released through not just guidance, but through very focused guidance. You see, at the moment in the World Health Organization and in most governments, COVID is being dealt with as an emergency. But because this is going to become a constant feature of society, I'm very keen that we move towards dealing with it as an endemic disease. just as we've done with HIV/AIDS as a society, and just as we've had to do with Ebola, but only in certain countries. So would WHO lead the global program? Well, there aren't many other groups that you can give authority for leading a global program other than the multilateral system and outfits like WHO. If there is a decision to set it up and to finance it, the debate will be more about how it's governed. When the global program on AIDS was set up, it had one global governance structure. When it was converted into the new UN agency, UNAIDS, a different governance structure was invented. Usually governments spend ages hassling about governance structure. If I have my way, it'll be set up with a temporary governance structure that will then be revised over time. But I would much rather not have the situation where you say we will wait 2 years until we've sorted out the governance before starting it. That would not be much use in the current circumstances. So my 4th P is program, and my 5th P is prospects for the future. On World Health Day on April 7th, we were reminded to think about equity. In listening to reports from around the world, the one thing that's becoming clearer and clearer is that COVID is deepening the gulf between rich nations and poor nations, between rich people and poor people, between well-financed companies and poorer companies. And it is, I believe, therefore contributing to greatly increased inequity and therefore to worsening the prospects of people who are already quite poor and who can't realize their human rights, and they are being pushed into even more difficulty and discrimination. So my slogan, which you've heard from me before, but I keep moving the words around, but it's fast, forward, fair. My slogan is based on the need to focus on moving forward, the need to include fairness, and the importance of being quick, because of my concerns that if we just dilly-dally on this, absolutely certain that more countries will go into civil unrest, more countries will face fiscal bankruptcy, and there will be a much worse situation by the end of 2021 than there was at the end of 2020. So in summary, my 5 Ps, which I will tend to come back to time and time again, are pandemic and what's happening, people as the answer, public health as essential, particularly at local level, a program on COVID for the world, which does everything from epidemiology through to working on vaccine distribution and follow-up, and then prospects for the future, where the fast forward fair approach is absolutely critical. So that's my quick opener. It's past now. I'm very keen to hear your reactions. I'm also keen to find out a bit more about how this kind of style of briefing is working for you. We may have to change the frequency, just go to 2 weeks rather than stay at 1 week when we go into the next series. But we are pretty keen to keep this going with the current format. And so the other thing that I'm very keen that you do is to, because we're trailing the fact that we're looking at the format, please don't hesitate to send us comments as to whether or not you would like us to continue, because it makes a huge difference. We feel this is a sort of family, which is one of the reasons why I wanted to go on like this. Twee, please, over to you.
Thank you, David. And indeed, on that note, I've put my email address in the chat there, so please feel free to send your thoughts on that, how we continue, to me. And thank you to those who have already shared what your thoughts are. It's very important for us. That's what drives us. So we have a little bit of a break here. I've got a bit of trivia for you, which I'll launch now. So 3 questions as usual. First question is related to measles. So between 2000 and 2018, measles vaccination resulted in a drop in measles deaths of how many? 55%, 34%, 73%, or 99%. For some figures to understand the situation in the year 2000, 72% of children globally were vaccinated. And by 2018, 86% of children worldwide were vaccinated. So what is that reduction in number of deaths? For question 2, when is a SARS-CoV-2 variant of interest considered a variant of concern? Now you can answer multiple times here. When the increase in transmissibility, or there's a detrimental change in epidemiology, when there's an increase in virulence or change in disease presentation, when there's a decrease in effectiveness of public health and social measures, like diagnostics and vaccines, or when it's assessed to be a variant of concern by WHO in consultation with the Virus Evolution Working Group. And the last question there, which of the following terms resonate with you? Now this builds on last week's question where we asked you about the healthcare professionals that you know or you may be and whether they're getting enough support. So this is about you and where you're at the moment. But I do have something more positive to share based on your responses. So I'll give you one more second. Usually we go to the illustration at the moment, but we don't have an illustrator here today. So I'll give 1 more minute.
If we've got a bit of a gap, I just hope that everybody who really feels ready to speak up has communicated in the chat. And while we're just having this little moment while we calculate, Catherine, are you there? I'm looking for you, you see, on my screen, and there's can't see you. Are you
I am here, of course.
Well, you see. Catherine, do you want to say anything about these issues? You and I have been discussing this super intensively all week. And also, is there anybody that you've spotted that you really want to be sure that we call on? Because there are lots of friends here, and I'm tempted to call on everybody, but we'll run out of time.
Indeed. I think it would be great if, so I believe that Claire Rayner and Assad Khan are online, and it would be terrific if we could call on them to speak to long COVID, which I know is an issue close to both their and our hearts. In terms of what I find most compelling, I'm really looking forward to all of the kind of things that you talk about coming next. I think the idea of how to position, create, implement a program to respond to COVID long-term is super exciting, and where that might land in the comment section on that. And so I think that there is some interesting opportunities for talking about that. I think the other things that are interesting are the fact that for the first time, we've talked about leadership a lot in this OOB session, but I think for the first time we're seeing real opportunities for global leaders to step in and collaborate. So we have this treaty, we have the upcoming Health Assembly, we have various places that there's really promising signs. But then, David, I don't know if you want to touch on some of the more distressing aspects of the AstraZeneca hold in some countries, because I think that's a less positive forward-looking sign. So those are the things that are occupying me today. I hope that's helpful.
I'm talking over mute. Sorry for that. I think that many people do that. Great, Kat, thank you. Everybody, Catherine, Twee, and I, together with John, we meet every day and we focus on this stuff. I'm very grateful to them for constantly being with us. And I think we will almost certainly end up in a situation where we do this more as a team show than as a David thing. Let's see how that one comes as well. So somebody else said 73% besides me. Over to you, Twee.
Well, the answer is indeed 73% there. So a great massive reduction in death, but still for me quite fascinating, there's still only 86% of children worldwide are vaccinated. On question 2, the answer is all of the above. So all of these are ways which mean that a variant of interest becomes a variant of concern. And at the moment, I believe there are 3 variants of concern, which you can find out more information about on the WHO website. And then for the last question, most familiar with crisis fatigue. So on that note, I'm just going to share an illustration as we miss live illustration today. This was just one infographic that we found available this week, which we thought was really helpful. In particular, the accept in the middle: acknowledge, compromise, calm, empathize, participate, and trust.
Oh, that's from Ben. That's from Ben. Brilliant.
So if you get our newsletter, I have included the link to that in there as well. But thank you so much.
So everybody, if you can just look at this picture, on the top right corner is a graphic of a gent with black hair called Ben Ramalingam. I would just like to really thank Ben, who's not here, but who's become a good friend of us through COVID. I'd like to thank Ben for drawing us attention to this tweet. Yeah. Thank you. So I'd love to go now. Claire, I think you're here. There you are. Claire, come in and tell us where things have got to in your getting long COVID onto the map. On my screen, Paul Garner is next to you. So Paul, you're on notice. And if there are other colleagues who would like to come in, just 10 minutes on long COVID. And if I'm right, Claire, this is my starter. If I'm right, that long COVID affects 1 in 20 of known COVIDs. Well, if there were 805,000 new COVID cases yesterday, day before yesterday, that is, if 20% of those are going to have the debilitation that you've all had in long COVID, this is like a grey cloud over the world. And it made me want to very much hear from you how you're feeling about things. Off you go.
Yes, thank you. And I've brought my colleague Asad Khan, who's a respiratory physician in Manchester, who's really been working on the front line as well, but is now has long COVID as well. And Harsha Master is with me, who runs a clinic in just north of London in Hertfordshire. And we've been obviously keeping our eyes on this thing all the way along. What concerns me from the long COVID point of view is exactly what you've just said. We only need to, extrapolate from daily figures how many people are likely to end up with longer term problems. And I think that where we're up to is that I'll speak as an occupational physician. People have been ill for over a year. A large amount of these people, the 1 in 20, are not back at work. They have either lost their jobs or they just cannot get back into work. So I've been particularly working with the Society of Occupational Medicine here, who have seen this. The occupational physicians have seen this in the workplace. They are completely aware of the physical problems that are resulting from long COVID. And in particular, the ones that are impacting on people's daily function are the autonomic dysfunction. Obviously fatigue for a lot of people, but I think that's a result of lots of other things that people with long COVID have. There's organ damage, there's, as I say, really significant problems with autonomic dysfunction, which impacts daily. And what concerns me probably most of all is the neurocognitive impact. And that is as completely separate from anything like anxiety and depression. We're talking about people cannot remember things. It's like having early dementia. And for my money, this is totally predictable from what we know of the 1918 pandemic. I think this appears to recover in many people, but is not recovering in some people. And this is one of the main things that's preventing people getting back to economic activity. These are people that are highly motivated to do so. And the other pattern that I've noticed and my colleagues have noticed is that there are different timeframes to this. Many people seem to get better around the 3 months mark, But if you don't get better around the 3 month mark, actually different pathology comes in. Autoimmune or other immune related stuff seems to come in. And we know this from what we know of cardiac diseases and so on from other viruses, and also in neurocognitive things. So there seems to be a shift of either getting new problems at 3 months, new physical problems, or worsening of things like the cardiac problems. And I don't think this shift at 3 months is well noted. It doesn't happen in everyone.
Okay.
But these are the problems. And this is, yeah.
Sorry,
Yeah.
I thought you might have come to an end. Were you going to
I'm
say
so sorry.
something else?
Well, I was
How are
only
you
going to, one other little thing you asked me to say about on the basis of an exchange that you and I had last time was the public health angle, the prevention, the looking at preventing people getting so ill that they need hospital. Basic measures like hydration. This virus makes you sleepy. And I think we need to get the educational looking after yourself, relatives looking after other people at home with real basic public health messages.
Wonderful. Thank you very much, Claire. I have to say to you that to have the courage to do what you're doing, despite the challenges you've faced with your COVID, is massively impressive. But there are others on the call that I would like to hear from as well.
Yeah.
Could Asad Khan, then Harsha Master, and then Paul Garner be ready just to give super short embellishments of what Claire said? Asad, please.
Hello. Yes, so I'm a respiratory physician. I contracted COVID in November, so I'm month 5. I just wanted to sort of back up everything that Claire said. One further complicating factor is that with the different pathologies, such as the dysautonomia, the mast cell activation syndrome, etc., that we're seeing, there is very little knowledge and recognition of these amongst clinicians, including clinicians running the long COVID services. So patients are actually struggling to get a diagnosis, and I'm a healthcare professional myself. It was only through talking to other doctor patients with long COVID that I figured out what was wrong with me and was able to take that information to the people looking after me. And it really worries me about lay people as to the struggles they're going to face to even get a diagnosis, let alone get treated. It is, unfortunately, there still seems to be this perception amongst doctors seeing long COVID that it's in the mind and it's stress and it's anxiety and it's fatigue, and some people are just breathless, taking a bit of time to recover. There is serious pathology here. There's myocarditis, there's dysautonomia, there is central nervous system damage, there is the neurocognitive aspect, which I suffer from as well. There are people who have lost spinal cord function. There are people who have undiagnosed encephalitis that's been lingering for months and months. And I think the estimate of 1 in 20 that you mentioned, I believe that there are some other series where they've looked at this, and it may be as high as 1 in 8 actually, which is even more worrying. At the moment, we estimate 1.1 million people in the UK have long COVID, and we are still counting the damage from the second surge. So the pandemic, even if it does stop suddenly, the damage will not stop.
Asad, thank you so much again for your bravery. Thank you for sparing the time to join us. Harsha Master, would you like to add? It's not time for me to embellish between. I just need to hear from you.
Hi David, nice to meet you. Thank you for letting me join. So my name's Harsha and I'm a GP by background, and I was asked to develop a long COVID clinic last year, back in May, when we just came out of the first wave. At the time, we really didn't know what we were going to see, and when we went live in August, we basically had to develop a pathway at pace, and with very, very little national and international guidance. It's been hugely challenging. I will agree with Claire and Asad, the patients that I've been seeing now, we've had over 400 referrals into our clinic since August. Our referral rate month has tripled. All the people that are coming through, many of them are really unwell, and some of them are still, some of the ones I'm seeing this week, for example, you know, was sick in March last year, so they're a year on and still really quite sick. And as Claire said, you know, the neurocognitive problems, chest pains, breathlessness, fatigue, lots and lots of issues. As I said, it's been really challenging because no one really knows how to manage this or what to do. And when I approach different clinicians, I'm met with different responses. Some people are really keen and want to investigate and engage, and others are very skeptical and say that it's post-viral and will get better, which doesn't really help me. What we have found is that a combination actually of medical assessment and rehabilitation has been really, really helpful. We've had to do this pathway, as I said, at pace and through trial and error. We've just tried various different things and you know, tried to see what works. The medical assessment is very, very important. And, you know, I do believe that there is some pathology that we will find because they are so sick. But the rehabilitation is also really important. And, you know, services like pulmonary rehab that help with the breathing and chronic fatigue, for example, we are very lucky to have a very good chronic fatigue service, and we're finding that, you know, that earlier intervention into that does help, but only after they have been medically assessed and investigated. For me, it's a really big problem. You know, I would really like some more guidance. We're quite limited by funding. I think that really does need to be addressed. So yeah, I would say this is an ongoing issue, and I'm interested to see what WHO thinks about long COVID and what your plans are for it.
Thank you, Harsha. Where do you practice, please?
So I work in Hertfordshire, in East and North Herts. So I work for Herts Community Trust.
I will try to get the WHO team that work on long COVID to join us on one of these. They have been quite influenced by some of you, obviously by Claire, but also by others as well who've been on these calls, particularly Robin Gorner and Paul Garner. So I will do my best to see if I can get the team here, but I will give you plenty of warning in advance so that you'll know if we're going to have a long COVID discussion. Thank you so much, Harsha. And now to Paul Garner. I come to you, Paul, always because you and I have basically been working together in various ways for 4 decades, and we've got to know each other quite well over the period, and you really woke me up to this. So tell me where your thinking is now.
So long COVID is a catch-all for a number of different conditions. There's a lot of argument at whether this is a super special disease or actually it certainly resembles other post-viral syndromes with a few extra bits in it. Never has a post-viral syndrome been investigated to the degree that COVID has. So, you know, there are, so it is a mixed bag of things. And part of the arguments relate to that. And the other argument, but what I've been finding really interesting is working with Norwegians on this. And clearly there's a stress response to the virus, which actually is centrally mediated and would explain an awful lot of what's happening in long COVID. The immune system, the nervous system, the POTS, the cardiovascular, the rapid heart rate, the skin and so forth. And part of it is how the mind and the body interact with each other. And it's this point that people think that I've lost my mind, because I've sort of gone from an evidence-based person to talking about how the mind can influence the physical illness that you experience and is actually there as an illness. But I think part of the solution will be around understanding how the mind and the body relate together. This does not mean that the illness does not exist, and it does not mean that it's not in the head. So, I think these are all going to be important as we go forward in doing research and helping people recover.
Many thanks, Paul. And everybody who's giving these short little vignettes, super appreciated. And Paul, you're among very, very good friends here, as is Claire, as is Assad, and Harsha. If you come again, I hope you will feel very welcome here. we are like this every time we meet. We give space. Now, I wanted just to hear from people who are coming in from around the world. Are you seeing long COVID in your geographies? NK SETI, you've been sending me really quite scary data from all over the place in India. Would you like to comment? And I noticed that Assad and Paul are not agreeing on the chat. I probably won't dip back into this. If you'd like to do it on the chat, and then we can pick it up again later, just because we're going to run out of time in 7 minutes. But noted, Assad, that you've written something. Look forward to seeing how you and Paul take that forward. Thank you. NK, India story.
Yeah, India, whatever is happening, is unfortunate.
Yeah.
But specifically to your question, long COVID, yes, it is, but has not been studied to a great extent. Right now, the priority is towards tackling the massive increase. And the previous speaker also mentioned, we are now talking about long COVID. I can give my own experience. Once I had some viral infection and I had cardiomyopathy and I had some problems for a long time. But having said that, it's very important that right at this stage, we do something to see that we are able to address long COVID. Thank you.
Thank you, NK. Just to say, it is NK SETI who has been sending me figures about the test positivity rates in different states of India. Maharashtra and Chhattisgarh, very, very high. And the city of Pune, very disturbing. Not good at all. Thank you very much, NK. Please keep
David,
come in.
David, yesterday in Delhi too,
Uh-huh.
the positivity rate touched 20%. A day prior, it was 18, 19%.
Yeah.
God knows what is going to happen hereafter.
Can you just say anything? Are the spikes in the same communities as where you had the big COVID in Delhi last year, or is it in different geographical locations?
Geographical locations remain almost the same, but the groups which are getting more affected are the ones who are a little better off.
Okay.
And double mutant variant is also emerging, which is somewhat very peculiar for India.
So I read about the double mutant today. This is a mutation on, I think it's the UK variant, which is causing a lot of concern in India. The reason why I asked whether the spikes are in the same geographical locations as where the COVID was last year is as follows. There's a big community of epidemiologists who've been saying that in Delhi, there was an awful lot of asymptomatic transmission. So in Delhi, there's reported to be a much higher degree of antibody positivity, suggesting that a lot more people had the disease than were recorded as having the disease. But then the figures I had more recently suggested that actually a lot of the communities that were having COVID this time around are the same as the ones that had it before. So it just has me questioning whether that stuff about asymptomatic COVID in India was as important as it was. And I see NK shaking his head. I mean, you know, there was this long period when people were saying, why hasn't it come back in India, NK? And they were saying it's because of the asymptomatic, but now it's come back so incredibly heavily, and it must make you all think, what is going on? I suspect it's variants, don't you? Last word to you.
Well, about geographical location, it is also now has started increasing in the hinterland. Earlier on, it was predominantly focused to urban areas, and within urban areas, now more of affluent society, but shifting to the hinterland also, deep remote areas as well. That's the situation.
Thanks very much indeed. I'm just going to people who've written comments, and because of so little time, I've got to find one person who I would be willing to talk. I wondered whether or not we could go to Africa and just see whether our friend Magen from Botswana, who tunes in quite often, Magen, is your internet good enough for you to speak? Are you there? And can you click the button and unmute yourself? There you are.
Yes, yes,
Hello.
David. How are you?
I'm good. Personally, I'm good. Very, very good. What about you?
Yeah, I'm trying to survive. Yeah, vaccination is apparently been stopped. They won't say why, but we are suspecting they are responding to the news about clothes. I don't know whether we had any in Botswana, but people are registering and they're now being told that the vaccine is used up, which we don't believe because they just vaccinated about 16,000 people after they'd bought over 65,000. So we're not so sure what's happening, and it's bringing anxiety because people want to be vaccinated because I think they will feel safer. But now we are just being told whenever we go to the centers, we are being told there is no vaccine. So we don't know what's going to happen because we had AstraZeneca.
Now, let me just quickly, I want to go to John Atkinson before we finish. Let me just quickly say that looking at what's happening in a very small number of people, there's a side effect of the AstraZeneca vaccine, which is that the people develop antibodies against their own platelets. Platelets are needed for blood clotting. If you basically attack your own platelets, the blood gets thin. And what happens then is that it starts to try to clot. So it thinks it's getting thin because of bleeding, and it's clotting away because that's what blood does when it gets thin. But by starting a clotting system inside the body, you then get the potential for these clots to go and land in different parts of the brain or other places, and then they lead to strokes and death. But the incidence is super, super low of clots from AstraZeneca, and it's quite low, super low clots from J&J. And so these are suspensions, a part of the normal thing that you do when a vaccine gives you suspected side effects. They're not signs that there's anything wrong with the vaccine. And the incidence of the clotting is much, much smaller than if you're taking your contraceptive pill. It's much smaller than the incidence of clotting if you get COVID. It's much smaller than the incidence of actually risk of death from all sorts of ordinary things like being in a train crash or a plane crash. But anyway, we've got this issue, and some say that this is fueled by the funny politics that's going on about vaccination. I try to keep out of that. All I'm saying is this is not a major side effect. This is a very, very low incidence thing. And if we weren't dealing with the current sort of intensity of almost immediate media reaction to anything that goes on COVID, the vaccine would have been considered okay. It's not a level of side effect that would normally lead to the non-approval or the cessation of use of a vaccine. It's just what I'm hearing. John Atkinson, final words from you before we close, please.
Very quickly, David, I'd just like to bring attention to a conversation in the chat about workplaces between James and Peter, and to say that that's something that we've found is that at the start, we were focusing quite a lot on food processing, for those who've been joining us for some time. Now, the place in England, at least, where we're seeing spikes of infection is around warehousing. But the linking factor often has been terms and conditions of employment as much as the actual physical conditions in this work setting, because people who cannot afford, because they're not on secure contracts, they don't have long-term sick pay, they cannot afford to isolate, are continuing to turn up to work together. And so whenever we think about what's happening in COVID and workplaces, I think we need to look much further than just, are we keeping them clean? How far distant are people? It's a broader systemic issue when we see spikes around workplace environments.
Very important, thank you. And one of the most dangerous workplaces is a prison. And what is it? It's because of the physical location. John, thank you for making that point. I do want to just greet Sarah McFarlane. I see you there now in the top left-hand corner. I hope you're well. Thank you very much for joining us today. I tried to greet each of you individually. I wish I could, I can't. Thank you for coming. Thank you for the messages. And so I go to Twee now for closing us, please. Thank you.
Well, thanks for joining us today. We'll be back next week. That is the 8 a.m. Central European Summertime session. Join us there. And in the meantime, you can find a lot of the community on LinkedIn. If you'd like to join us there, send me a message on LinkedIn. I'll put a link in the chat. Otherwise, back to you, David, for the final goodbye and smiles.
Okay. So that is it. And it is bye-bye and thank you. And, life is great. And we are all able to meet together in this way and enjoy, despite the fact we're talking about something pretty horrendous. Thank you all for being here. And with that, and with a special thanks to Claire, Assad, Harsha, and Paul for the little vignette on long COVID and all of the Nazim material from Vicky and the invitation to the concert on Monday. With that, we all say bye-bye. The hour has slipped by just like that. Thank you. See you next time. Looking